Hi everyone, happy Monday. I am really excited today to talk to Dr. Carolina Sueldo about your biological clock. And this is a very hot topic, and I am just waiting for her to come on. Hi,
Prabakar,
happy
how are
Monday.
you?
Hi, Doc.
Thank you. Thank you. I know
I'm
I normally
great.
don't
How
work
are
on
you doing? Happy
Mondays, but I just so
Monday.
happened to come in for a procedure for a special patient. So catch me, yeah, just after.
Oh, well, oh, thank you so much for spending a few minutes with us. Hello, Amor Sweets. Amor Sweets, by the way, makes the best cookies for anyone here in the La Morinda area. Hi, everyone. Thank you so much for joining. And today we have Dr. Sweldo. We are going to be talking about the biological clock. And this is something that patients ask me questions about all the time. It's a very important topic, especially given the times we're in now, right? Like women were having kids in their 20s before, then
Yep.
it became 30s, and then it became 40s, and now people are even thinking about 50s. And so before we get into all that, please tell our viewers, our listeners, a little bit about yourself and, where you are,
Absolutely,
and what
absolutely.
got
So
you
I am,
into
for
this
those that don't know
field
me,
of
I'm Dr.
reproductive
Carolina
endocrinology.
Sueldo. I am double board certified both in OBGYN and reproductive endocrinology. I'm currently practicing in Central California, so just a few hours away from you. And basically, the main reason I went into women's health, it was really about empowerment. I realized in med school, I became sort of the like friend physician for all of my girlfriends who had questions. And I realized that even the most educated women were so
Yeah.
uninformed when it came to their bodies and their reproduction. And so there was a big piece of me that really wanted to empower women to know their bodies, to understand their bodies, understand their options. And that's really where it came from. And so I did my residency in OBGYN, and during that time got exposed to the IVF lab. And to this day what they do I think is just so phenomenal. Like it really is miraculous. And that really just the nerd in me just went, wow, what is this? And my mind was blown. So I ended up doing a 3-year fellowship after my training. I went to Florida. So my first job out of fellowship was with a practice in South Florida. I was there for 3 years. And then since September of 2018, I've been back in the Central Valley.
Got it. All right. Yes, it's just fascinating. And as you
Yes.
said, your mind is blown when you think about the microscopic things that are happening to get these babies, right? It's amazing. And
Yeah.
so
Let's get
let's
right into it.
talk a little bit about the biological clock. And yeah, and what something that patients ask me all the time, like, you know, we're in the Bay Area, a lot of career-driven women in tech, especially, but really in all fields, who are delaying having kids until sometimes in late 30s or even early 40s, mid 40s. And so something
Right.
that patients ask me all the time is like,
Yeah.
well, when is that cutoff? Like,
Yeah,
is
so I
there a
think the
cutoff?
first thing,
And so
I
what
understand
would you
that
say to that?
talking about the biological clock can be a touchy subject. We as women have progressed in so many other arenas of life that reproduction, talking about this real biological clock can sometimes be scary or even offensive to some people. But I do think it's important to just understand biology because then that allows you to understand your options. So what I tell, the way I start is that women are born with
Mm.
all the eggs they're going to have in their lifetime, and they lose those eggs as they get older. Now, really, if we're being sort of textbook about it, our peak fertility as women is actually in our early 20s. So like 21, 22, somewhere in there. But what we know in today's society is that most women in their early 20s are either studying or working and are not really thinking about a family. And so childbearing or family building has been significantly delayed compared to years past. And so really the data comes from populations that did not use birth control. What we saw is that after age 35, there was a natural decline in fertility. And what we saw is that the same fertile woman who had 2 kids, she was trying for a third, at 35, her chance of pregnancy was roughly about 20% per month. That same woman, same fertility, but age 40, it was about 5% per month. So we saw that there was this drastic change over that 5-year period. And then once you get above age 40, that decline is much more dramatic. So with each passing year, the changes are much more significant. So it is important, and we do know that the biological clock is real. It is ticking, and so it's important for women to understand what exactly that means so that they can plan ahead for it and really take it into consideration along with, you know, am I going to do the post-grad? Am I going to get married now or later? Am I, you know, et cetera, et cetera. So that needs to be sort of one more variable in their life planning.
Yeah, absolutely. And I think, as you said, I think for a lot of women, it's sometimes we don't want to come to grips with that. Like, yeah, there is a clock. Like there, could be a limit. I remember I
Right.
had a patient who was like 54
Right.
who came to see me and she's like, well, what do you
Right.
mean? Like, I can't have kids. Like she just very nonchalantly said that to me. And I was like, you're like pretty much hitting menopause right now, And I remind a lot of women that, for
Mm-hmm.
whatever reason, I feel
Yep.
like just rates of infertility, even in younger women, are increasing over time, especially in the last decade. So even those of us who were, in our mid 20s, were like, oh yeah, it's not going to be any problem to get pregnant, are finding that it's become a challenge for many.
Yeah,
And so I almost feel like you never really
absolutely.
even know that
Yeah, so
you can't take it for granted. You can't take
The
it for granted
CDC
that, oh
data, which is
yeah,
now probably
we'll
a
try to
couple
get
years
pregnant and
old,
boom, it's going to
talks
happen.
about the numbers of 1 in 5. So about 15 to 19% of the US population has difficulty with reproduction. And if you think about 1 in 5, if you think about a group of girlfriends and there's at least 5 of them, at least one of you is probably going to have or is having difficulty with fertility. And, age is definitely probably the most important factor, but it is not the only factor. And so I have young women who also have issues with infertility, and it's important. So just in terms of general education, I think you're never too young to know and understand these things or these concepts so that you can plan accordingly.
Yes. Hi, Dr. Una. Great to see you here. So, other than age, as you said, that is not the only factor. What are some other factors that you are seeing in your practice that can really affect fertility and that can really
Yeah,
put,
sure. So the first
impair women from just
yeah,
getting
the
pregnant right away?
first thing I like to say
There
is
are
that
some,
general health
metabolic
is
diseases. Yeah.
reproductive health.
So, I'd love to
So
hear
if
from you.
your general health is poor, your reproductive health is also probably being impacted, because we know that diseases like high blood pressure, diabetes, obesity, autoimmune diseases like lupus or Hashimoto's, all of those have the potential to impact fertility. So really optimizing your general health is so, so important. So outside of age and outside of lifestyle or chronic disease management, we also talk about things like, number one, are your cycles regular? So, especially in my younger women, they're like, no, I get 2 periods a year. It's great. I don't have to worry about it. So what I always tell people is, if you are a young, healthy person of the female gender, then you should be getting a regular, monthly, predictable period every month. And if you're not, then that warrants an investigation. The caveat to that, of course, is if you're on some form of hormone suppression for any reason. But outside of that, it should be monthly, it should be predictable, and it should be cyclical. And if it's not, then you need to understand why. The second thing I tend to say is that if your periods are so painful that over-the-counter meds are not helping, you're calling out of work or missing school every month because they're so painful, it's impacting quality of life, you can't be intimate with your partner, that is not normal. And I think, you can probably speak to this better than I can. I think as a field, we've gotten much better about this, but ACOG not that long ago published that women typically were seeing 5 doctors before they actually arrived at a diagnosis of endometriosis, presenting with pelvic pain of some sort. So I think we've gotten better at recognizing that, but I definitely want patients to understand painful periods like that, that's definitely not normal. And that definitely needs to be evaluated. The additional thing I'll say, let's say you or your partner for infertility, things like STDs, or things like pelvic surgery of some sort when you were a child, or, you know, God forbid, a history of cancer and you had chemo or radiation. These are all things that are going to be super important to know because they can impact your fertility. And then lastly, I do like the caveat of, if you are trying and you are anxious, even if you don't meet any of these criteria, just see someone, because potentially you can have the counseling discussion. You may or may not decide to get tested. And then if everything comes back normal, that may calm some of that anxiety as you're in that fertility journey.
Yeah, that's a great point. I also love what you said about STDs. I think a lot of young women don't even pay any attention to this, but part of the counseling that I do in the office is, hey, if you had gonorrhea or chlamydia, guess what? Like that could actually be scarring your fallopian tubes and can lead to infertility. I've seen women in their 30s where this has happened and they're just completely shocked. Like they had no idea that this was a consequence of, you know, having those STDs. And so
absolutely,
that's just part of.
Right. And I think a lot of times people are expecting a symptom, you know, irregular cycles, heavy periods, something, right? But a lot of times with tubal disease in particular, it may not present with any symptoms, which is why tubal assessment is part of the standard evaluation, even in the absence of any risk factors.
Yes, and this is why it's important to see your GYN regularly, because we are doing chlamydia screening, you know, gonorrhea, chlamydia, all the way up to 26 yearly. And then, of course, if you have any high risk, behavior or sexual activity, or, you know, if you have any discharge or anything that's concerning, just bring it up to your gynecologist. So let's move on to the topic of egg freezing, because this is hot. Everyone wants to look into this now. I know here in the Bay Area, a lot of the tech companies are actually offering this as part of their benefits package. Which is incredible. And I think for a lot of patients who really, they're like, okay, I'm 32, I don't have a partner yet, I'm getting really anxious, they're utilizing it. And then I'm seeing the flip side also. I'm seeing younger women in their 20s who are like, I have a benefit, let me just freeze my eggs. And so it's just happening all around. And one of the most frequent consults I do to reproductive endocrinology is egg freezing. And so I would love some information for our viewers and our listeners on egg freezing.
Absolutely.
What is
so let's start. I'm actually going to start backwards. So I'm going to actually start with what is egg freezing, and then we'll come back to who should consider freezing their eggs. So as far as egg freezing is concerned, the idea is you want to block out a 2-week block. So it typically involves fertility injections. Those injections are subcutaneous, which means just underneath the skin. You do them once a day, roughly for about 8 to 10 days. And over the course of that week and a half, we are seeing you for fairly intense monitoring with vaginal ultrasounds and regular blood work to check your response to the medication. So we're monitoring your response. And at the end of that 8 to 10 day period, we'll plan for the egg extraction or egg retrieval procedure. That egg retrieval procedure is typically done in an operating room-like setting. It is typically done under what's called conscious sedation, which is a type of anesthesia. Typically, you are not allowed to drive. You are not allowed to work that day. The procedure is done transvaginally. And what we're doing is we're inserting a needle through the pelvis, and we're taking out the eggs that we've been monitoring on the vaginal ultrasound. And then the next day, you'll typically get a phone call saying, hey, the 15 eggs we got, or whatever number we got, these were the number of viable or good ones. And so these were the ones that we froze for future use. So in a nutshell, in a 2-minute version, that's what egg freezing is. The interesting thing about egg freezing is that it hasn't been around that long. So ASRM, which is the American Society of Reproductive Medicine, only removed the label of experimental back in 2012. And the reason for that is because of the lab. So freezing techniques pre-2010, 2012 were called slow freezing techniques, and the eggs did not survive well in that environment. So the survival rate when you went to use them was very low. Post that era, we shifted to something called vitrification or fast freeze, which allowed for much better survivability. So now when we talk about egg survival from the freeze thaw process, we talk about an 80 to 85% average, which is significantly better than what it used to be. And so now women have this option that really only became available in the last decade, which is not that long. In 2012, I was starting my fellowship, and I've been at it almost 10 years. So it really hasn't been around as long as people think. And, you know, the idea is that because of this good survivability and because of the fact that there's only one owner, right? Because the eggs just belong to the one patient. Now, even in married women, we are advising or counseling about the option of egg freezing. And the reason for that, some people may be familiar, there were a couple high profile cases, particularly in Hollywood, where embryos, so that's now you have egg and sperm, so now there's two owners. The embryos had been frozen previously, and they were now in dispute between the two partners about usage, who was going to have ownership, et cetera, et cetera. And even though everybody signs documents at the time in the fertility clinic, those documents are not legally binding. And so then typically the couple has to go to a court proceeding, and then ultimately the court decides, you know, what they think is the best outcome. The fertility clinic then has to act on that court order. So even for married women now, with the survivability of eggs, we are encouraging patients to consider the one versus the other option. As far So that's with regards to egg freezing. As far as who should get their eggs frozen, so that is a great question. I don't know that we have a black and white answer to that. Certainly what I would say is that ideally, in a perfect world, you want to have a patient who is under the age of 35, because we know that the egg quantity and the egg quality are going to be at their optimal best. Once the woman starts to age over 35, it's not that she can't freeze her eggs. We absolutely still do it, but they need to understand the limitations as the number of eggs and the quality of those eggs begins to decrease. Within that group of under 35, there's a wide range, right? If you talk to a 22-year-old woman versus a 32-year-old woman, there's probably a big difference. So then other variables start to come into play. So one question is, do you know if you want to have a family or not, right? So some women may choose not to. Some women may be unsure, etc. Number two is, do you have the finances, or is it something that's covered by your employer? So in the Bay Area, you guys are really fortunate that a lot of women have coverage. That is not true for most U.S. women. So the vast majority of U.S. women do not have coverage and are out of pocket for it. So most women have to think about this in advance to be able to plan and save, just like you would save up for a vacation, for a car, for a house. And then the third thing is understanding that egg freezing is not a guarantee. Egg freezing is an insurance policy. It's a backup or an alternative plan, but should not be viewed as a guarantee. So always when I'm counseling egg freezing, I think it's a great option. I did it myself, so it's something I'm very passionate about. But I want to make sure women understand what happens if we get there and none of the eggs survive the thaw. Or what happens if we get there, we make embryos, and then those embryos do not result in a pregnancy, right? Because implantation is not 100%. So it's always making sure that, yes, egg freezing is available. Yes, if you can do it, awesome. But also thinking about, okay, what does my family plan look like? Particularly in women who are around that 35 and over age mark. Typically, me personally, I'm counseling, hey, are we ready to get pregnant now? Because if the answer is yes, then that should be the goal. And only in the setting of, hey, look, pregnancy is just not an option for reasons A, B, or C, then I would say, okay, then let's consider egg freezing as an alternative priority or a second line treatment. So hopefully that makes sense for your audience.
Yes, that was such good information. So if you just joined us, I'm chatting with Dr. Carolina Sueldo, who's a reproductive endocrinologist, fertility doctor, about your biological clock and egg freezing. If you have any questions, please drop it in this chat below. So two things I wanted to highlight from what you said. The first is, you know, when we talk about fertility planning and you ask a couple, are you ready to have kids? And the answer is yes, then you know, that should be the option one, not egg freezing or embryo freezing necessarily, because that is, you know, natural conception is going to be more efficacious, more cost effective, all of those things. And you have a partner, right? And you're ready to have kids. So, what's the issue? Unless there are other things, of course, if you're genetically screening for certain diseases, etc. But for the average couple who's ready to have kids, then, go for it. Don't keep waiting. And the second is, egg freezing is not a guarantee. And even when we think about insurance, right? Like if I talk about car insurance, my car gets dinged up. Okay, maybe I pay a little deductible, but then they're going to cover the rest of it. Like I'm pretty sure by the end of the day, I'm either going to get my repairs fixed or, my car fixed and my repairs paid for. But with egg freezing, it's not like that. Like, right? Yes, you store your eggs, but it's not even insurance in some sense, because there's no guarantee that like you're going to get anything out of it. Like at least with my car insurance, I'm getting some repairs paid for. But with egg freezing, I mean, yes, that may work, or it just may not. And now you may be 10 years older than you were when you froze those eggs, and you may have nothing, right? Like, I think that's so important for women to understand, because something that I see, and I think women are misled either by social media or whatever they hear in the news, or, some celebrity that they see doing this at 50 is, I have patients coming in at, 44, 45, and they're like, okay, I'm just going to freeze my eggs because whatever, if I don't find anybody in 4 years, I'm, that those eggs are going to work. And I cringe a little bit because I'm like, well,
Yeah.
not necessarily. Yeah. So I love that you said that, okay, under 35 is probably the best, time to freeze your eggs if you're going to freeze them. Do labs and fertility centers have a cutoff where they will say like, okay, after this age, we're not really going to be using those eggs for IVF or,
Sure.
IUI?
Sure.
Like, so tell us a little bit about that.
My disclaimer, my disclaimer with that is I will say every clinic is different. So you definitely want to talk to that particular clinic to see what their policy is. There's not really a black and white guideline from the society itself. So each clinic is kind of left to determine that for themselves. For me personally, so I'll speak to my personal counseling, if they are under the age of 35 and have a normal egg reserve, or an appropriate, I should say age appropriate egg reserve, that is sort of the ideal candidate. Mm-hmm. If they are over the age of 35, so between 35 and 40, and they have an appropriate egg reserve, I will counsel how I mentioned earlier. Pregnancy first. If pregnancy is not an option, then egg freezing second. If they're over the age of 40, I am generally trying to discourage from egg freezing. Mm-hmm. Now, it's a little bit tough, and the counseling definitely needs to be individualized. But the concept is that typically, and again, we're talking about the average 99%, not that 1% exception, for the average woman over age 40, her egg reserve or egg quantity is typically quite low. And we know that not only quantity is being impacted, but also quality. So the likelihood of getting a sufficient number of eggs frozen to then have a reasonable chance of pregnancy in the future is really low. All of that said, if the woman is clear in her understanding of all of that and still wants to proceed, I will not say no. I will let them go forward, because at the end of the day, my feeling is it has to be their journey and patient autonomy. But I am very blunt and I am very black and white about, hey, over age 40 or even between 35 and 40, this is what the numbers look like. Based on your egg quantity testing, this is what we expect to get. Are these numbers, is this making sense to you? Are you tracking? And is it something that you still want to consider? And a lot of times what will happen is in testing the egg quantity and seeing those low numbers, a lot of times then, the conversation starts to shift and like, oh, well, maybe I do need to consider pregnancy, or, oh, maybe I do need to consider third party, which is a whole umbrella within IVF where we talk about sperm donor, egg donor, embryo donation, so egg and sperm from someone else, or surrogacy. And, that segues into my next point that I was going to make, which is, most of us have never had to think about this, right? So most of us grow up avoiding pregnancy, being responsible, using birth control, using condoms or whatnot. And so once we get to a place where we're like, well, do I need to think about egg freezing? Or what if it doesn't happen for me? Or what if my biology is not sufficient? Would I even consider someone else's egg? These are all thoughts that really take a lot of processing and a lot of time, thoughts and feelings to work through. So, you know, the example, I always give my own personal example, you know, I'm a fertility specialist. I deal with this all day. And I started thinking about egg freezing at 30. It took me a whole year, so till I was 31, almost 32, before I decided to actually go through with it. Because there's so many, it's not just the process, right? There's so many other thoughts that have to come into play and that have to be sort of digested before you're comfortable exploring or going into that option. And so the sooner you're aware of that biological clock, the sooner you understand, hey, there is a limit or there is a benchmark where I need to be, you know, thinking about this, then it can help kind of guide some of that thought and some of that planning.
That is a great point. I mean, I even bring this up, women in their mid-20s, early 20s. I mean, before, like, that's not even something you would consider, right? People are going to grad school, people are, whatever, they're not having kids right now, but it is, the more it comes into your world, your periphery, you're thinking about it, it's stored somewhere in your brain, you're able to access it and, you know, figure it out if that time comes and when that time comes. So yeah.
And then the other point, sorry to interrupt you, the other point I wanted to make too is, you know, people have this thing about, oh, my 35th birthday or my 40th birthday or what. So I just want to be clear. It's not like something magical happens when you turn 35, right? Like, this is all a continuum. But for the purposes of research and the studies, we needed to create these artificial benchmarks so that we could counsel patients and also unify the criteria for research.
Yeah, that's a really good point. Awesome. I mean, this has been, I mean, you've given us so much great info. Do you have any like last like parting thoughts on just fertility tips, or, you know, how to maximize your chance of, you know, getting pregnant even? That's another huge question that patients are always asking. And of course, as you said, your general health is your reproductive health. So obesity, diabetes, thyroid issues, high blood pressure, these are things you definitely want to control. But what about, you know, can you think of anything else? There's so much research coming out now on, you know, products that we're using in our body, and there's so much that's really unknown even. But
it's like
you know, that's like
overload.
It's like Pandora's box over there. But when it comes to that, but any, you know, in your field, in any of the meetings you've gone to, anything that you have seen recently where it's like consistently coming out that, okay, these are maybe some risk factors for reproductive health?
Yeah, so I want to answer that in two parts, if that's okay. So the first one is, you know, specific risk factors. To your point about the increased rates of fertility, we know, or we have seen that post-industrial revolution, as a human race, we are being exposed to more toxins than ever before. Post World War, I think it was I or II, with the advent of plastic, we're now exposed to plastic particles and other toxins in a way that we never were before. And we know there's actually good data on this. And I think we're just beginning to scratch the surface of the impact on all of those exposures to our reproductive health. And there's actually good data. Our firefighters, there was a study on hair salon workers. So anyone who has that toxin exposure prolonged over time, we do see an impact to fertility. The other thing you mentioned, lifestyle. So of course, obesity, nutrition, but sleep is another one. We see that night shift workers, for example, have increased risk for irregular cycles and infertility. People who have sleep disorders, sleep apnea, or insomnia. So I think, you know, when you're looking at your lifestyle per se, like nutrition is important, absolutely, but I think that's just one piece of it. And I think really looking at the whole picture. Are you using plasticware at home or glassware? You know, little things like that. What makeup products are you using? You know, et cetera. So those types of things I think are super important as far as risk factors are concerned.
Yeah.
And then the second piece, as far as takeaways. So number one, you know, be informed, educate yourself. I think that's super important. But number two, this is a message that I like to give to all audiences, is really being a self-advocate and really being proactive about your health. I think that when you have a good rapport with your doctor, that allows for you to ask questions. hey, what do you think about this study? What do you think about, you know, this thing that just came out on CNN or whatnot? And really identifying a doctor who's going to spend the time and who's not going to be annoyed or irritated by those questions, that will welcome those questions and have that discussion or that conversation with you. I think that's so, so important. And I think a lot of times we're educated or socialized to kind of, well, you know, wait for the doctor to refer me out, or wait for the doctor to think of, you know, ask about testing or whatnot. So that would be my parting words about self advocacy.
That's fantastic. And you know, the fact that we have social media now and we can watch, you know, lives like this, I think are even better, right? We don't have to wait for that appointment, you know, with our doctor. We're getting valuable information from other physicians on social media. So I think that's fabulous. Well, I mean, thank you so much for spending your afternoon off, you know, with us. And this was so great. You've given us a wealth of information. I see a bunch of people just joined. Hi, everyone. Definitely watch this. Go back and watch this. Dr. Sueldo has given us so much important and useful information about our biological clock. We've talked about that. We've talked about what affects the biological clock. We've talked about egg freezing and just tips on reproductive health. So I think this is all great information. Please tag a friend who could, you know, use this information, and tell us where we can find you. And, you know, if those who are watching and listening want to learn more, how can they do that?
Absolutely. So I am currently licensed both in California and Florida and plan to maintain those. So if you reside in California or Florida, I can see you as a patient. If not, you can definitely find me across social channels. I'm pretty active here on Instagram. I also have a Facebook page and I have a YouTube channel. All of them with the same name, so it's easy to find, Dr. Carolina Sueldo. And if you go back and watch this live and you have additional questions or just comments about what we talked about today, send me a DM. I would love to hear from you.
Great. Well, thank you so much. And thank you everybody for watching. Have a great rest of your Monday. And we'll be signing off from the Fibroid Doc. And we will see you later. Bye. Bye.